Good morning. I'm Dr. Samruddhi. I'll be presenting a case on bilateral neurotrophic keratitis in a case of hereditary sensory and autonomic neuropathy type 8. There are no financial disclosures and the patient's parent consent was taken for all images. The parents of an 11-month-old child noticed bilateral redness and whitish discoloration in his eyes since 10 days. The child was fourth born of a non-consanguineous marriage and had also a history of no crying after intramuscular injections, reduced sweating all over his body, mutilation on his body by scratching, and ulceration of his lower lip following teething. On examination, the child had bilateral minimal congestion with loss of corneal luster, minimal corneal edema, and punctate keratopathy, and was diagnosed with bilateral stage 1 neurotrophic keratitis. He also had a reduced blink rate of less than 4 per minute, bilateral absent corneal sensations, a partial blink, but did not have lagophthalmos. He had developed angular cheilitis, a bald tongue with loss of his papillae, and ulceration of his lower lip. On systemic examination, the child had hypotonia in all 4 limbs, absent deep tendon reflexes, but his head circumference, milestones, and remaining systemic examination was normal for his age. We did an electromyography, nerve conduction studies, and sympathetic skin response, which revealed bilateral sensory neuropathy in lower limbs, along with autonomic dysfunction in all 4 limbs. His systemic investigations also revealed severe anemia with hemoglobin levels of 5.8 gram%. Genetic testing revealed a mutation in the PRDM12 gene, which was responsible for causing HSAN type 8. The patient was started on preservative-free topical lubricating drops and ointment in both eyes and was worked up for examination under anesthesia with SOS tarsography. He was at a high risk of GA as he had risk of developing hypotension, gastroparesis, abnormal muscle spasms, as well as severe hypotonia with muscle relaxants. The patient was lost to follow-up and he presented 3 weeks later with increased redness in both the eyes. On examination, there was severe congestion with bilateral central stain-positive corneal epithelial defect with edematous and rolled-up epithelial edges. He had progressed to bilateral stage 2 neurotrophic keratitis and eventually developed bilateral corneal scarring. Bilateral tarsography was planned, however, as the patient awaited fitness for GA, he was again lost to follow-up. Neurotrophic keratitis is a rare degenerative corneal disease due to damage to the trigeminal innervation. And HSAN encompasses a group of disorders which have sensory as well as autonomic dysfunction. Traditionally, it has been classified by Dick and Ota into 4 types. However, now newer forms are being recognized. Type 8 HSAN is classified as an orphan disease as very few cases have been documented so far. And as we can see, the clinical features in our patient, all of them have been seen in previous cases of HSAN type 8. The PRDM12 gene encodes a transcriptional regulator which has a critical role in pain perception. Hence, mutation in this gene leads to type 8 HSAN. There are various treatment modalities that are available for the treatment of neurotrophic keratitis, like traditional options including topical lubricating drops, tarsography, autologous serum tears, as well as amniotic membrane graft. Emerging new options include scleral lenses, surgical corneal neurotization, topical insulin and nerve growth factor, and botulinum toxin injection in the levator. To conclude, I would say that HSAN type 8 is a rare genetic disorder with very few prior reports on its ophthalmic manifestations, and it requires a multimodality approach for successful management. Hence, it is important to make ophthalmologists aware about such emerging causes of neurotrophic keratitis so that they can be diagnosed and treated early and severe corneal sequelae can be prevented. Thank you.